Good morning, everybody, and welcome to the first day of summer. Exciting, the first day of summer. It's always an exciting time. It's my mother-in-law's 88th birthday today, so that's also great. On behalf of all of us at the Benefits Trust, I'd like to take this opportunity to thank you for coming and spending a little bit of time with us. We've got a special presentation today. Dave Wochuk is going to be joining us, and I'll introduce Dave a little bit more formally later on in the presentation. As I mentioned, on behalf of all of us at the Benefits Trust, thank you very much for coming. A couple of us are here today. I'm just looking around the screen. Carrie Lane is in the house. Hello, Carrie. Mike Ignatz is with us, and my son Rob Crowder is also with us. And there's going to be more people joining because I think another meeting that a lot of people are on. We're just finishing up. For participating today in our spring Zoomcast series, even though it's the first day of summer, everybody's going to get a CE credit for participating today. So that'll be sent out by Mike Ignatz in a week or two. So you will be getting that. So stand by. You will be getting that CE credit. As well as that, we're going to send you a real short survey. Please fill it out, send it back. Tell us how we did today, because we want to do it better tomorrow than we did it today. As simple as that. And this presentation today about drug cost management and strategies for protection and effective drug cost or effective plan design is really feedback that we receive from you. So it's important that we get the feedback so we can have things that are of value for you to get CE credits and you actually get something out of them. So that's important. As well as that, today you're going to be signed up for our Trusted Advisor newsletter. If you don't get that already, well, good news, you're going to get it. And there's lots of valuable information, and that comes out monthly. We encourage you to visit thebenefitstrust.com as well. Lots of valuable information there. So what I'm going to do is I'm going to take a moment to share my screen. And there it is right there. Share. And play. Everybody can see that?
Very good.
Perfect. Everybody can see that. So today, as I mentioned, we want to talk about drug cost management, or drug cost management strategies for protection and effective plan design. And this is all about, I think, mitigating risk. If I look at this, and just come up with a couple of words, it's about mitigating risk. A benefit plan is nothing more than a promise between an employer and an employee or a group of employees. And that promise can often be defined either very specifically or very loosely. And I think when we're talking about plan design and drug cost management, it's all about mitigating risks. So our agenda today, we want to talk about risk analysis, who benefits from using effective drug cost management, protection, and effective plan design. So is it the employer? Is it the employees? Is it both? Is it you, the advisor? We're going to talk about that. Client needs analysis. When and where do you use drug cost management, protection, and effective plan design? What is drug cost management, protection, and effective plan design? Reporting and taxation, why drug cost management, protection, and effective plan design is important. We want to go through a couple of case studies, and we want to have some questions, answers, and discussions. Now, on the call today, Chris Bonet is with us, and Chris is one of the leading experts in the country, without a doubt, about drugs, about all things drugs. Would you say, Chris? You're going to say?
I think that's a little scary, but yeah, I follow it as closely as possible, and it's a pretty dynamic field.
Yes, it's a pretty dynamic field, and Chris is without a doubt an expert in this. So if you have any questions, please either raise your hand on your emoji or simply throw it in the chat box, and we're all going to be monitoring that. Well, I won't be, but Rob and Mike and Carrie will be monitoring that. So, and as well as that, Chris, if we can call on you from time to time, or if you want to chirp in, that would be awesome, because your wealth of knowledge, I think, would help the entire room. So we'd appreciate it if you jump in. And point of view, I think it's important to look at this from a specific point of view, because you just can't look at it as from a benefit plan perspective from all benefit plans in Canada. So we're focusing in Ontario. Right now in Ontario, there are 450,000 businesses. A couple of keystrokes when I put this together, found 449,770 businesses. Let's round that up to 450,000 businesses in Ontario. 440,000 of those businesses have less than 100 full-time employees. And the other thing is, Toronto has more cranes right now than most U.S. cities combined. More cranes than New York City, more cranes than New York City, more cranes than Washington, San Francisco, and there was another one in there, I think, combined. So there's a lot going on in Ontario. Ontario is a very vibrant place, and when you look at southern and central Ontario, You look at the Golden Horseshoe up to Guelph and across to Barrie and, down to Oshawa in the east. In that whole area, there's just a ton of business and a ton of opportunities. So it's an exciting time, in my opinion, to be in the benefits business, because especially when you're looking at less than 100 full-time employees, because these people need your help. These employers definitely need your help. They need your help as part of their employee benefit program, as providing superior advice to them. So when we're looking at this, it's how can we do this? How can we provide value-added services at a profit? And we've got endless prospects, 440,000 prospects. If everybody here gets another, 20 cases in the next year or so, we're not even scratching the surface. And it's really through this lens that we're going to explore the opportunities that exist, specifically with respect to plan design and drug cost management. So I think it's just a great time to be in the benefits business, without a doubt. A little bit of a disclaimer: Benefits Trust started on January 1st, 1994. Our target market list, if you would, our target market where we love to work with is with advisors like yourself, and where your target market is less than 100 full-time employees. Since we're putting this on, without a doubt, these are our views and our opinions. And we love to listen to people that have other great opinions as well, or disagree with our opinions, but as long as they, have some backup and we can talk about it. That's how we all learn. I think in this space, in my career, I've had easily in excess of 10,000 sales meetings in this space. So I've got some racetrack behind me, without a doubt. And this is really not a commercial for the Benefits Trust. Nudge, nudge, wink, wink. But really, it's about giving you folks some information that you can use in your practice in an effective way to create value and create profit for yourself. So let's jump right into it, because we got a lot to cover today. But when do you use drug cost management? Well, I think it has to do with a number of factors. Sometimes it's important to clients, sometimes it's not, but it's really when clients are risk adverse to rising costs. I think everybody's, adverse to rising costs to a certain extent, but some people just kind of shrug their shoulders at it because they're so focused on what it is that they're doing, the widgets that they're polishing, if you would. But I think, drug cost management is really effective, especially in smaller groups, when clients are risk adverse to rising costs. It's as simple as that. So the question is, how do you know if they're risk adverse to rising costs? How do you know that? It was interesting because I just remember this conversation I had years ago in one of the sales meetings, and I was saying, hey, risk adverse, rising costs, and they go, we don't care. You don't understand. We don't care. We want to have the best for everybody. So, everybody's got a different definition of risk. Everybody's got a different definition of risk. So it's entirely up to the client. And how you're going to find that out is really by asking those questions. Are you risk adverse? And the best way to know where your client is going, and the best way to determine the best way to help them, without a doubt, or even if you want to help them, is you have to ask. And you got to ask future-based questions. And I harp on this every time, because every time we do one of these Zoomcasts, because I think it's so important, right? We have to ask future-based questions. Remember, selling, whether you're selling widgets or whether you're selling benefits or whether you're selling iPhones, it doesn't matter what you're selling. It's engaging someone in a future result that is good for them. It's engaging someone in a future result that's good for them. And the best question I've ever heard, and I've been using for at least a decade, maybe even longer, was one that was created by Dan Sullivan and shared by Dan Sullivan at the Strategic Coach. And it's quite simple. We were meeting here 3 years from now, and you're looking back over those 3 years. What has to have happened for you to say it's been the best 3 years of your life? And it's fascinating because you can ask that question to your prospects. You can ask that question to your client. You can ask that question to your client over and over and over again every time you meet with them. You can ask that question to your friends. You can ask that question at a dinner party. You can ask that question anywhere. It's fascinating what people say when you ask that future-based question. Again, selling is engaging someone in a future result that's good for them. This is going to give you, the answers is going to give you a roadmap of where the client is going. A roadmap of where the client is going. And if someone was to ask me that question, because I think that's important to illustrate my point. If someone was going to ask me that question, all right, I would answer it and I would say, we are in the business of growing the Benefits Trust. We're still in growth mode. We have been since 1994, but we're not going to do it through acquisition, right? We're not going to do it through acquisition. We're not interested in selling our business at this point in time, or any point in time in the near future or the distant future. We're not interested in merging, right? But we're interested in entering into new markets through associations and different ways of distributing our product, with advisors, of course. And we're constantly looking to develop new products and new solutions. So, it's giving you a clear roadmap of we're going to grow, and we're going to develop into new products and new markets. And it's going to give you a sense of their risk tolerance level. Coming out of that question, if I was asked that question, people would find out that I'm risk conservative and I'm not going to risk what we have. It's as simple as that. Maybe that's hindering our growth to a great extent because we're not willing to sell, we're not willing to merge, we're not willing to grow through acquisition, because that's just the conservative approach that we have. So I'm very conservative when it comes to risk adversity. So you got to ask the question, where's your client going? And you got to ask them future-based questions, because it's important for them to give you a roadmap, so you can determine, first of all, if you want to help them, and B, the best way to help them. So what is drug cost management? What is drug cost management protection? Well, it means different things to different clients, without a doubt. It means different things to different clients, and it really depends on where they're going and their future. But it really means different things to different clients. You can look at plan maximums. Great, we're just going to throw in a $5,000 drug plan. Well, there's drug cost management protection, right? We're just going to put in a maximum, $5,000, $7,500, whatever it is. Managed formularies. Formularies are just part of the promise that an employer is making to an employee. We're going to talk a lot about that today with Dave Wochuk, but managed formularies. We're going to talk about coinsurance. Great, we can have, a 80% coinsurance, or 80% coinsurance up to a certain level, 50% after that, or 80% up to a certain level, then 100% after a certain level. You can do all sorts of different things with coinsurance. Maximum dispensing fees can be included as well. Per prescription deductibles, preferred pharmacy networks. So we're going to talk about that as well. So it's really, drug cost management means different things to different people. Certainly it means different things to different clients. So it's important to understand where they're going and getting their temperature for their risk adversity, if you would, and to be able to discuss all of these things in a powerful way. But why is it important, especially important for small groups? As I mentioned, there's 440,000 businesses in Ontario with less than 100 employees. Well, I'm willing to bet 300,000 of those companies have less than 30 employees. So they're small, without a doubt. I hate using the word small business. I hate when someone calls the Benefits Trust a small business, because I just like to say it's a profitable business with few employees. People that work at the TD Bank laugh, but they go, no, you're a small business. But I'm going, whatever. I don't think we're a small business. But it's important to spread the risk, because some groups, with a standard employee benefit program that's out there, and they've got a large amount pooling built into it, and that large amount pooling might be $10,000. It might be $7,500, depending on the carrier. It might be $12,500. But all of a sudden, if one claim comes in, because you as an advisor or another advisor hasn't advised their clients appropriately of the risk, if one claim comes in, it could have devastating results, financial results that the client isn't prepared to pay for. Then they're into a whole other strategy on what they have to do to maintain their employee benefit program. So, for example, if you got a small group with 10,000 if you got a small group with 10 lives, annual premium for that case is going to be around $30,000. All of a sudden, if that $30,000 of expenditure that they're using for their employee benefit promise, all of a sudden, if they've got an unlimited drug plan and they get a $10,000 or $50,000 claim, they get a $50,000 drug claim. It's going to increase the cost to the large amount pooling. They're going to raise their rates considerably to recover that money back up to that large amount pooling level. And sometimes the financial results can be devastating in the plan to the client, and the client has to make drastic decisions. And the other thing is, they've got one, geez, what happens if they get another one, right? Because sometimes lightning does strike twice, right? It's as simple as that. So, there's a big opportunity here. There's a big opportunity. And I've got pro tip. This is a great prospecting conversation, because a lot of advisors don't talk to their clients about this. So I think there's just an enormous opportunity from a prospecting perspective, as well as a client management perspective, to talk about drug cost management and some of the tools that are available that can be embedded into a plan to protect them So their plan continues into perpetuity, because remember, this is all about the client and the client's future and where they're going and helping them with that roadmap. All of a sudden, if their plan becomes too expensive or far too expensive for them to pay for, they're going to have to cancel the plan and demotivate their employees. That's going to not help them reach their goals. It's going to hinder them from reaching their goals. So it's important to ask that future-based question and have these risk management discussions with your clients. So I thought that it would be appropriate when I was putting this presentation together, because I thought it would be appropriate to invite my good friend, Mr. Dave Wochuk, to come along. Dave Wochuk has been with Claim Secure for 30 plus years. We've had a long-standing relationship with, the Benefits Trust has certainly had a long-standing relationship with Claim Secure, but I've had a great relationship with Dave Wochuk as well. And Dave's been in this business, as I mentioned, for 30 plus years. He knows the stuff backwards and forwards. And I'm going to pass this over to Dave right now, who's going to share some slides with you. Hopefully, Dave.
Yep. Can you hear me, Rob?
Yeah, I can hear you. So
Okay, perfect.
I'm just going to turn mine off for a second. And there we go. And then I'm going to go over here and oops, nope, wrong button. Sorry. I'm going to allow you to share in 1 second. There you go, Dave. Now you can share your screen, and over to you, Dave.
Okay, thank you. Let me just share. I'll ask the question, but I think you guys can see it.
Most definitely.
Okay, great. I'm on full screen right now. I don't have a second monitor, so
Yep.
if there's questions, I can answer them afterwards, or you can just interrupt me and ask the question. We have a little bit of time, so I think we're in good shape. Thanks, Robert, for the introduction. I can tell you that Rob and I have been working for 30 years, and what I love about Rob's business is he's really into the cost management and trying to protect the benefit program for the long term for the employer, and that relationship and that philosophy is totally in line with the way Claim Secure is. Our parent company, Canada Life, I would suggest, is more into risk management, and they want to make sure that they price things properly. We're into trying to figure out ways to manage costs. So there's a little bit of a fundamental difference between us and our parent company. And to that end, my background, by the way, before being 30 years in this business, I was 10 years in the pharmaceutical industry, working for Merck Frost and Eli Lilly in different positions in sales and marketing, international marketing. And so I've been weaned on drugs for the first 10 years of my career, and spent a lot of time in this space. So looking forward to presenting today to you on a program that we have, which specifically address the cost of specialty drugs. And that program is called Formulary Protect. So, one of the challenges that we hear from the advisors that we work with is, how do you have a solution to be able to help me manage the cost of these specialty drugs? And in the past, they say, we fully insure it, and we go through our renewals, and they're very uncomfortable. We have ASO with stop loss, and as Robert said, as you have these renewals, you see a huge increase in your stop loss rates, or they increase the attachment levels, and then the final sort of choice you had or solution you had is put in a drug cap. And I think that does help. It does help for the plan sponsor themselves, but the challenge I have with that is that the drug cap is really to try to address these specialty drugs. You hit that drug cap really quickly when you have a specialty drug, and now you have all kinds of collateral damage in that you don't cover any drugs after that you hit that drug cap. So this program is unique, Formulary Protect, because it addresses the specialty drugs, if you will. It's more surgical in nature. It's much more precise in that if the problem is your specialty drugs, then give me a solution that addresses the specialty drugs without having collateral damage on coverage for all other medications. So, here's the challenge that we're seeing. And I remember, a number of years ago, it would be trying to convince people that specialty drugs were a problem. And today, I think every single advisor in Canada has experienced a client who's had these specialty drugs. Some clients are nervous about them. Some clients are totally paternalistic and will just continue to cover them or happy to. But more and more we're seeing, give me a way to manage these costs because they're out of control, seeing a bad renewal, and as important, mitigate the risk for future exposure to these specialty drugs. And the challenge with these drugs is that there's more of them, a lot more of them. The range for which they cost has increased, and we're seeing some that are, almost topping $2 million right now. It used to be for drugs that are nth line therapy, and there was a fairly small group of indications that they work for, but today they're used for a lot of additional indications for these drugs. It's also for very ultra rare diseases. We're also seeing them for more common diseases also. So more drugs, higher costs, more common conditions, more ultra rare conditions that cost a lot of money. It is truly a challenge in how we go forward. This program is not for everyone. It's for your plan sponsors that basically have moved from a total paternalistic position. I have to cover medications for everybody all the time, to one now is I can't manage the cost of these medications and continue with a benefit program. And I don't want to be the financial safety net for all these high cost drugs that are coming out. So what is our solution? Well, the product is called Formulary Protect. I can tell you that we have over 5,200 clients on this. It's been in place since 2016. For those that are out there that like to wait and see how this program progresses, I think after 7 years and 5,200 clients, I can say that's been well tested. But basically what Formulary Protect is in the simplest form, it removes all specialty drugs from your formulary. So those are the drugs that cost $10,000 or more. That's sort of the universal definition of a specialty drug. It removes all specialty drugs from the formulary. And at first, glance, you're sitting there and getting a bit of sticker shock and saying, well, if you remove all these drugs, how do they get covered? How does an employee who have one of these medications be looked after? Because that's quite an egregious or aggressive kind of approach. In doing this, the first thing you have to talk to your advisor is that, can you afford the cost of these specialty drugs? And if the answer is yes, then this program might not be good for you. Can you afford the second, the third, as Robert said at the start? Can you afford the fourth? When is your break point for when you no longer can pay for these medications? And, no disrespect to stop loss or fully insured programs, you can see in your renewals that it's very challenging. And I think the other problem is that if you try to shop a situation out where you have people on specialty drugs, any carriers now require you to give them, a report on all the pool claims and a list of which drugs they're taking. So that follows you in your history, and they quote or don't quote based on that. So why does this program work? Why do we have 5,200 clients on it? And some advisors are actually promoting this on every single one of their renewals. It's because of the second part of it. This is sort of the secret sauce, and that is that we don't cover these medications, but then we have a whole team of people in our clinical department that try to find alternative funding for this program. And the actual service is called coverage navigation, and it has three components. The first is finding alternative funding, and the three major sources that we look for are the spousal plan, seeing if they have a spousal plan, and we're about successful in about 10% of the opportunities that the individual actually has a spousal plan, and we can defer it over to the spousal plan. The second is through the provincial programs, and we're successful about 30% in that space. Now, appreciate when I say provincial programs, I'm talking about provinces in Canada, with the exception of Quebec. In Quebec, because of RAMQ, you are not allowed to remove drugs, and that includes specialty drugs off of RAMQ. So this program, disclaimer, works in provinces other than Quebec. There's a couple of other provinces where the co-pays and financial assistance is somewhat limited, and I can talk about that a little later on when I show you the results. But for the most part, most of the provinces, you can probably get provincial coverage. Provinces, generally speaking, like to be payer of last resort, but if your program is not covering it, the provinces are a good avenue to go to next. Some of the pharmacare provinces are more generous with their programs, and we can get coverage earlier on. And then so 10% of the time we're successful in spousal plans, 30% of the time we're good with getting provincial drug plan coverage. And the final one is we go to the pharmaceutical companies and ask them for support through their patient assistance programs. And we're about 20% successful at going to the pharmaceutical companies and getting assistance. And then sometimes there's a combination of 2 or 3 of these, and the combination of 2 or 3 of these, we're also successful about 30% of the time. So that's the first part, is we're actually very good at finding alternative funding. So the messaging when you're talking to your client is that you put in this program in place, but you have a coverage navigation service which will help handhold your employees through the gauntlet, if you will, of finding financial assistance for these medications.
Dave, can I ask you a question?
Sure, yeah.
So the $10,000, any drug that's considered high cost is any drug that's annually 10,000, correct?
That's correct, yes.
10,000 or more.
Right.
10,000.
And this plan would not cover from $1, right? So any drug that is deemed to cost annually 10,000 from $1, it would be removed from the core plan. Is that correct?
That's correct, yes.
And then if a client has 80% coverage, is the idea through the funding alternatives to at least get them covered for the same 80%, or is it to get them covered 100%?
We're going to try to get them covered as much as we possibly can.
And if you're using a source like Trillium with deductibles, how does that work?
Okay, let's use that $10,000 example. Let's say they have 20% coverage, so that's about $2,000 a copay that they'd have to pay, right? So in Trillium, if you go to Trillium, they'll have a 4% net household income deductible. So if my math is correct, they're used to paying $2,000 on the 10. If they had a 4% net household income, I think they would have to have an average of $50,000 for their net household income that they would have to pay 10,000. Hang on a second. Let me do the math. What am I doing wrong, guys?
That they'd have to pay the 2,000 for.
Right. So they have to be making about 100 and
right. It's 4% that's paid quarterly, right? 4% of household income paid quarterly.
That's right. So if they're making $100,000, they would have to pay the first $4,000, right?
Right. I wasn't referring to a $10,000 drug. I was referring to more like a $100,000 drug.
Yeah. So in that case, they'd still have to pay the 4% net household income, and that's all they'd have to pay of that $100,000 drug.
So
right.
they'd be covered more than 80%.
Right. But in a scenario where they were covered at 100% and now they have to go to Trillium and pay 4%, they could actually, by implementing something like this, they could be out of pocket in a situation where they weren't previously.
Great call. That's exactly the situation. Not a perfect program, but that's right. You would actually increase the cost to that individual in the copay based on that scenario you gave. Yes.
And Dave, to mitigate that, do you find that employers are bumping up salary to net the Trillium copay? Is that something employers are doing as an alternative? Or number two, and I'm not sure, I don't believe you can do this, but I think some brokers are actually putting deductibles through a health spending account, which I don't know if that's really kosher.
So again, you know a lot more about this than most. The great questions. I would tell you that this is being recorded, and our position always is that you are not allowed as an employer to reimburse the individual for any portion of that 4% net household income. Okay, that's the official answer.
And there are some creative ways depending on the employer. Again, is it perfect? Absolutely not. Who do we work for? We work for the client, right? And the client is implementing this program based on their risk mitigation, temperature, if you would. Nothing is perfect unless you have 100% of everything and unlimited money, right? But it's just, this is, again, just a promise that the employer is making and helping with those costs to a great extent, but protecting their interests in the long run. So I think it's important, Dave, if you can continue, because love your questions, love the interaction, but we got a lot to cover. So we could talk offline as well.
That's fine. I'll just, one last comment, that'll be that I've seen all kinds of creative ways that companies have tried to figure out that equation. But CFOs and the owners that I've spoken to said, if you're mitigating all future risk for all these specialty drugs and removing most of the costs, leave that problem with me. Okay, that's sort of how it goes. But we cannot reimburse somebody through a health spending account. So coverage navigation, the second part of the service is that we actually help the individual person filling out their application forms for provincial coverage, giving all the drug history, giving a letter showing that the private plan is not covering it. So we make sure that when they submit the application, when it's done, and then we give them an envelope too, that it goes into the provincial adjudicators and it is complete. And the provincial adjudicators see one of our envelopes and they know that it's a complete file. So just human nature, they'll pull one of those things out of the pile. The only province where that is not true is in Alberta. They have a librarian and it's a first in, first out policy. So we get in queue. Normal times for the applications to be reviewed and approved is usually less than 90 days. On average, we're seeing about 58 in Ontario. In Alberta, it's about 93 days. So that gives you a sort of a range. And then the final part of what we do is we advocate on behalf of the client or the member themselves. So if we have to deal with the provincial administrator, we will. Obviously we've signed privacy waiver forms with the patient, so they've given us the ability to do that. So we talk to the provincial administrators, give them any information they may need. We also talk to the case manager that might be signed by the pharmaceutical company. We also will talk with the physician if necessary, and the manufacturer from the pharmaceutical companies if we're through assistance of that. So we basically take on all the heavy lifting to help that patient out and try to make that experience the best possible. So, you know, if I could just sort of summarize what this Formulary Protect looks like. If you look at all the medications, and remember, there's just regular medications, or what we call standard prescription drugs, and then there's specialty drugs, which by definition are groups which are drugs over $10,000. Our normal formularies will cover all your standard prescription drugs, but any drugs that are over $10,000 would not be covered on this program. And it doesn't matter whether they're listed on the provincial formularies or not. That just helps us with funding. We do have another hybrid called Protect Plus, which does have a little bit of a deviation or a little bit of an adjustment on some of the specialty drugs that are covered by the government formularies or not. But would take a little bit too long to explain that. It's called Formulary Protect Plus. If you want more information on that, I'd be happy to get on the phone and explain that to you.
And we've got information on that as well.
Okay, thanks, Robert. Appreciate it. So the next part is, well, let's say we go with this, Dave, and we want to know what's happening. How would you transition an existing a group that has existing people that are already on these drugs? We'd identify them. Hopefully we can identify them in advance, but because of privacy legislation, sometimes the employer does not know who that individuals are. So we usually find out directly after, but there has been some communication that the employer has given to all of his employees to basically say, if you are on a medication that's a high cost drug, please call this number, or we'll find out in the first time when they go to get a drug. We'll find out who they are, and we'll proactively identify them, and then send out an application form for them to fill out and a waiver so that we can start working with them and engage them. And then we'll try to work on getting an application completed for them to the provinces, the spouse, or the pharmaceutical manufacturer, or all three of them. And we will continuously follow up with the member to let them know the status of trying to find the medication and the coverage. That's for people that are on the existing, and appreciate that when you're an existing, or when you're a member with somebody who's on one of these drugs and we take it over, we will continue to pay for that drug or cover that drug under the plan during the application process. So that 90-day window, or however long it takes. So there's no loss of medication during that time. Reality is, when a group comes over to us and that the communication has been sent out that we're moving over to another company and this drug is not going to be covered, members will go out and they will use their existing carrier and they'll go get at least a 90-day fill or something. So they're usually loaded up prior to coming over. But we will continue care and coverage until we get the application completed. Now, there is another situation that is, okay, we put this program in place. Now we have, we're 6 months into it, and we have one of our employees now all of a sudden is not newly diagnosed with a disease, but they're given one of these specialty drugs now because everything else hasn't worked. Generally speaking, the specialist will warn them that there's usually you have to go through an application process to get these medications covered. But if they don't, and they just actually sent in a prescription, it would get rejected when they went to go get that. Then there would be a number that would be given to them by the pharmacist. The person would then phone us up, and we would start the whole process of the application, helping them the member through that experience through our coverage navigation services, and help them with looking at spousal plans, looking at the pharmaceutical companies, looking at the provincial plans, and helping them with the application process. And then we would continue to follow up with them throughout the whole process. Again, there are situations also where some specialty drugs are a bit more, I'll use the word ambulatory, but let's say they're cancer drugs and they can't wait necessarily, 60 or 90 days. There is, in some of the provinces, the ability to fast track some of the applications that we have. And we've been doing this for so long now, we pretty well know most of them, the adjudicators now, each one of the provinces. So in sort of summary, if you look at this program, on the left-hand side, you see the member has a claim. If it's a non-specialty drug or just a normal drug under 10,000, we adjudicate that claim like we normally would. If it is a specialty drug, which happens probably in less than 2% of all of our paid claims, in the number of claims, you follow the top process there, and you'll see that that person would go to the coverage navigation to help them assist in finding alternative coverage. We look at the spousal plan. That's the easiest one. If it is covered by the spouse, we'll try to move it towards the spousal plan. If not, we look at the province, and we try to see if we can get support through the provincial program. And if we do, we can also try to get some assistance if necessary through the manufacturer's program also. But if we can't find provincial coverage, then we'll also try to just go right to the patient assistance program. And it's usually a combination of 2 or 3 of those, being very common. So our results, and again, we've been doing this since March of 2016. We have 5,200 groups. If you do the math, that's a fair number every month coming on, somewhere around 30 plus every month that are coming on the program. And we've been 92% successful on the top right-hand side. And that 92% is a combination, as I mentioned, of government, pharmacy, the pharmaceutical manufacturers, the spousal plan, or a combination of them. That's 92%. On the formulary protect, because we do have some specialty drugs that we draw back into the formulary there's about another 3% success right there. But generally speaking, you can look at 92% of the time we have success. So one of the questions that comes up and says, Dave, that's great, but I like your plan, but what happens if all of a sudden the provinces change their whole funding process and they decide not to cover these medications anymore? 10 years down the line, I guess the first answer is, well, if 10 years down the line, if they decide not to cover them anymore, you're exactly in the same position you are today if you don't put this program in place. So you've only gained 10 years of coverage during that time. But I don't think that would be the position of the province at any point. And I'm sure Chris will have an opinion on this also. But I would think that if they did something, they would actually start to increase the coverage or make it national coverage of these specialty drugs, not remove it. If the provincial medical director ever removed it, the Minister of Health ever removed it, I think it would be political suicide for that individual, and it would be very challenging because they'd have a lot of bleeding hearts getting on the media trying to say they're not covering my medications anymore. If they didn't want to cover these medications, I'm sure that they would grandfather the people that are currently being covered. So I think it's a non-issue, and I've actually presented at conferences like KALU, where I've actually had the director from Trillium program, the EAP program, that was co-presenting with me and using this program as a springboard to talk about the value that the Trillium program offers by paying for medications that private plans won't pay for. So it's not perfect, but you have to have that reality check conversation with your plan sponsor and say, if we aren't able to get coverage for this individual, and that's, that call it 8% of the time. Are you willing to look them in the eyes and say, sorry, we do not cover that medication? And recognize that you cannot then turn around and all of a sudden try to cover it, because you'd be totally offside. Because then you wouldn't be, you can't be last payer. You have to either cover it or not cover it according to the rules of engagement with the provinces. So if they're willing to say that, remember, it's less than 2% of the time you're going to either have one of these medications and you're getting 92% of coverage and success. It's a way to get rid of the cost of the medications. So to the point is that it covers, from $1, you don't longer cover these medications. You're not paying the ASO fee on these medications. You're not paying stop loss fee on these medications. You potentially have stop loss that'll be cost you less because there's less risk. And that's a discussion you can have with Robert on that part of it. But the most important part for, independent of all the cost savings, is you're removing or mitigating the risk of all future of these medications being prescribed to one of your patients. And in business generally, if you have a $50,000 risk coming up in the next year, you do everything possible to mitigate it. We seem to be ignoring that in the drug space. So really, that's the end of the presentation. All I can say to you is that as an advisor, if you need help and support, if you have a client that you're interested in doing this with, you can work with Robert. Him and I can work on looking at the top 25 DINs by dollar. We can actually find out if, we know the province that they're being prescribed in, where your member is living. We'll be able to sort of pre-tell you as to whether the probability of us finding financial assistance through the provincial programs. And we can tell you, in advance. So when you go into that meeting, you'll say, hey, you got 3 guys on these specialty drugs, and it looks like we can get coverage for all 3 of them. So that will help you with any information in advance. We can also, in a larger case, we can actually do a financial summary for you to tell you what we believe the total cost savings will be, in the fact that you're not paying for these medications, you're not paying for the ASO fee, you're not paying for the stop loss on those medications, and your stop loss in general is lower. So there's a number of different savings that you have. And with that, Robert, I'm going to turn it back to you and answer any questions that you may have.
Dave, in the chat box, there was a question from Krista. Krista, do you want to ask it, or do you want me to?
Sure. I was just wondering, with all of the formulary management, if there's a pharmacogenetic component when someone has a condition and they're going to start trying all of the different drugs to kind of expedite things.
Not on this program, Krista. We haven't got into the pharmacogenetic part on this program. No.
Great question, Krista. Thanks for asking. Appreciate it. So
Rob, can I jump in for a sec, Rob, and just hit on one thing that Dave just said?
Yeah.
So you just mentioned about what happens if something doesn't make the cut. And I think the one thing you got to point out is, in a traditional plan, all drugs aren't covered either. And a lot of people see it as there's the ideal, and this is 8% off the ideal, but the ideal doesn't exist. Between prior authorization, programs like Drug Watch and everything else, there's a lot of drugs on traditional plans that are not covered either. So, it may not be as big a gap as you think it is. And the program works really, really well. So thanks, Dave.
Thanks for your comments, Dave. So, and Dave Wojcik, thank you very much for participating today. You add a great deal of value to these Zoomcasts. So let me talk about we've got a couple case studies where we've used this. As I mentioned, we've been working with ClaimSecure for many years. We were really excited when I first heard about this program. We put it in place in with a number of our clients. But in this particular situation, we're working with this advisor. They've got this company has 8 locations. They've got 300 plus employees. The core plan design included, to a great extent, an unlimited drug benefit. The drug claims experience was increasing year over year due to utilization and some high cost medications, but they didn't have any specialty drugs. They didn't have anything that was over that $10,000 range. But all of a sudden, the client's looking at the top 10 DIN report, and he's seeing drugs that are $3,000 and $4,000 and $5,000. And he's starting to, the client was starting to get nervous about this. It showed up on their radar. And he was, in this particular case, this client was worried about future plan benefit, the benefit plan stability. So this was something that was on his mind. The existing advisor, he brought it up to the existing advisor in the renewal program. The existing advisor basically had a really flippant attitude and said, put in a plan maximum. That's the only thing you can do. Put in a plan maximum. If you're really worried about that, put in a plan maximum. Anyways, the answer in this particular case did not sit well with the employer. This is a big case, and he was looking for advice and looking for alternatives, and just a simple off the cuff answer by putting in a plan max and changing that for the 300 plus employees really was not impressed with the advisor's advice. So the solution was a new advisor came in. They had a discussion. They had a future-based discussion. They discussed the risk mitigation problem that the client was having, and they said, amongst a number of things in the discussion, the advisor said, hey, one thing that I would certainly be looking at is implementing a $5 dispensing fee max. So you're encouraging people to shop wisely. You would put in mandatory generic substitution. And then they discussed the options of Formulary Protect and Formulary Protect Plus, which we'll talk a little bit about in a moment. But they decided that they were going to implement these particular changes because they thought that was a more appropriate way of mitigating the risk as opposed to just a hard drug cap. So it was kind of interesting. The results of this particular case was easy to manage since everyone has the same benefit plan coverage and design. Just as Dave mentioned, they can't be the last payer of last resort, so to speak. Everybody's got the same, benefit plan coverage. The client can provide a well-rounded drug plan that include cost containment measures that they were looking for. The provincial drug benefit program was utilized through Formulary Protect, and the patient, what's it called again, Dave? Sorry, it's the Formulary Protect, but it's also the patient advocacy program that the manufacturers have. Drug cost stability was achieved, or future drug cost stability was achieved through this program. And the new advisor's recommendation resulted in a new client relationship. And this was a kind of interesting because it was a one-meeting sale after there were satisfactory reference checks. So this particular individual came in and suggested, after asking some great questions and having a fantastic discussion, that resulted in an agent of record letter that was changed, and a result and changes to the drug plan were implemented based on his recommendation. So it's not always just, hey, hard cap. Don't have a flippant attitude, right? Advise your clients, but advise your clients based on the direction in which they're going. Case study number 2. Union and non-union employees in this particular organization. The business has 30 employees, including non-union and union employees. Community-funded social service industry, rural location. They're not, in the GTA. They're outside of the GTA. The union group is in the process. Well, the management and union group are in the process of negotiating a collective bargaining agreement, a new contract. Budget constraints. It's always a thing, especially when you're looking at community-funded social services. Budget constraints. The company is largely government funded. They wanted better cost control, and the union was aware of the implications. I can't even speak this morning. Implications of rising drug costs, and they wanted some plan stability. Excuse me. They wanted some plan stability, so that's what they were sort of presented with, and the Formulary Protect Plus was added to both the union and non-union groups to ensure future plan stability and affordability. Formulary Protect Plus is just like the Formulary Protect, but essentially, and again, we can provide you with more information about this offline if you're interested, but essentially what happens is you go to the Trillium drug, you go to the spousal plan, you go to the Trillium drug program, you go to the manufacturer for their patient assistance program. If still all of those things are exhausted, then it comes back and it's covered through the stop loss, right? So it's Formulary Protect Plus. So in this particular case, Formulary Protect Plus was added to both the union and non-union groups to ensure future plan stability and affordability. The union was in complete agreement of this benefit change due to little change in benefit plan design, just in process, right? There was no change in the benefit plan design per se. There was just change in the process of how people were dealt with when they had a specialty drug in hand. And the employees and union had very little pushback because there was no material reduction in benefits. Again, just a change in process. The employee group put this in as well as the union group, and everybody was on side with this. it was a really interesting thing because the result that was put in place, the future drug costs are more stable, without a doubt. Similar business unions are now interested in this creative plan design. And it's interesting because there's a lot of these community groups that are out there and they feel that they're a little bit different because they're in a rural community. So all of a sudden, this serves as a template for the advisor to go around to all these other groups and pursuing new clients, and they're using this as that template to get in the door, and they're having a great deal of success with that. So not only did this help the client, it also helped the advisor in getting new clients because he's using this as this creative card as a door opener and a discussion piece that a lot of people aren't bringing to the table. Again, 30 lives, right? Not a huge case, but certainly a great case. And it's not going away. Case study number 3, I call this groups within the group. So traditional plan design, 20 employee case, unlimited prescription drug benefit. And yes, Dave Patriarch, I've got your comments on board on this one, but unlimited drug benefit. Premiums continue to rise. The owner has a few long-standing key employees. The company has experienced high turnover with newer employees, and they're looking for a creative plan design to mitigate risk. The business owner also wants to take advantage of all government programs that are available because he hates paying taxes. A lot of business owners are certainly like that. They just hate paying taxes. And they go, why do we need a drug benefit? And I think the conversation might have started, why do we need a drug benefit at all? Because there's a Trillium program in place. Something along those lines, because the government or the employer really wanted to take advantage of as many provincial programs that were available. So it was interesting. This was a natural fit. Again, there were no claims. There's only about 20 employees in the organization, and there was no existing claims at this time. So it's easy to make that change without a doubt. And the employer wanted to take advantage of those programs that were available. So it was easy. What they decided to do was base the plan, or a lot of the plan, on years of service. The owner and the key employee with 5+ years of service got the Formulary Protect Plus implemented. So again, it's not covered by the spouses plan. If it's not covered by the Trillium program, if it's not covered by the patient assistance program, then fabulous, it comes back and it can be covered by the plan. So again, just change in process, no change in benefit. But employees with less than 5 years of service, the Formulary Protect was implemented. So to Dave Wochuk's point, he could look the member in the eye and say, yeah, this benefit is not covered. Then the client or the member hasn't been there long. And again, that high turnover component of their benefit or of their company, he says, great, I'm willing to take that risk. I'm willing to take that risk. The result was the key longstanding employees were recognized for their tenure in the company. Future cost containment with creative plan design was implemented, and the employer is happy with the government programs being utilized to their fullest when that is, ugly claim rears its head. It's going fantastic. I'm not paying, I paid the taxes on this, and you know what? I'm glad the program is being utilized. So it was this particular case was a really easy case study. The client secured the relationship. He secured the relationship even stronger than it was before. All we did was just change their plan around slightly. And the client was really happy with the advice, but the client knew, or sorry, the advisor got to understand all this by asking those future-based questions. Right? He had a great discussion with the client and learned these things. So it was easy to give him the very creative advice and plan design advice to be able to implement these programs and take advantage of it. And, his credibility just went up a number of notches in their relationship schedule, if you would. So tax accounting and reporting considerations as we're coming up to the close here, folks. Effective cost containment and regular reporting creates thin files and profitable long-term relationships. Right? It's critical to have these discussions with your client and make decisions, help your client make decisions and implement those decisions, and then show them on a regular basis with the reporting, and it creates thin files. Like I've never had a bad renewal. I've never had a bad renewal because of the reporting that we do with respect to our clients. It is something that we do on a monthly basis to you, the advisor, and to the client, so they see exactly where they stand from a financial perspective. And especially when you've got this cost containment in place, with the, some of these creative plan designs that Dave was talking about, right? It just eliminates your competition. It eliminates surprises. You never have a bad renewal, and it eliminates your competition. So we've talked a lot about this and we could probably talk for 2 days and taking deep dives into each of these things that we've talked about. But really, we just wanted to scratch the surface on this. At the Benefits Trust, we believe that an employee benefit plan is nothing more than a promise between an employer and an employee. And as a result of that, they can promise whatever they want. I'm just going to stop sharing so I can see you better. And it's interesting because this is a great tool. Is it a perfect tool, as Dave mentioned? No, it's not a perfect tool, but it's a great tool to have discussions with your clients and separate yourself from the competition, right? It works extraordinarily well. As Dave said, we've got 5,700 cases on file. We've got a number of those, and we've never had pushback when someone's actually had to use the program. There's never been any pushback. So we experience positive results. I know some of you that are on this call have clients with us that are probably part of this program as well, and you've never experienced negative results on this. So it works and works extraordinarily well. But again, not fix all for everything. Any questions, any thoughts, any ideas, discussions? Okay, so we're going to send you a survey. We want to thank you very much. And on that survey, we want you to tell us how well we did today so we can do it better tomorrow. On past surveys, just so we're clear, we've had people that have said, yeah, there's not enough interaction. Well, we asked the question, there's been some interaction today, but we asked the question that there's not enough interaction. And if nobody wants to speak, well, don't tell me that there's not enough interaction, because I can't control your questions or not. But anyways, does anybody have anything to add? Last chance.
Yeah, Rob. Michael.
Hi, Michael.
Good question. So with this type of plan, what does that add in terms of cost to the employer?
It doesn't add any cost. It doesn't add any cost to the employer at all. It adds zero cost to the employer. It's just, again, you're adjusting the promise that you're making, and you're adjusting the promise by putting in a managed formulary. The managed formulary says, hey, fantastic, we're going to cover all your drugs with the exception of all these specialty drugs that are $10,000 or more. So what that does, Michael, in a standard case is it, first of all, doesn't increase the employer's costs. It decreases the employer's costs, because with us, and I know with Dave and Claim Secure and Canada Life, it reduces the risk. Therefore, it reduces your stop loss charges. So with us, for example, the stop loss charge is reduced by 50%. And stop loss charges are becoming more and more significant because the risk is becoming greater and greater and greater. So when you implement a program like this, not only does it mitigate risks in the future in a great deal, but it also reduces their costs immediately by their stop loss reduction.
Okay, thanks.
Rob, I just want to add in that there's actually a $250 fee for a coverage navigation service. And that recognizes the help and support we give them on the application and the clinical pharmacist that's involved. So, and we have never had a complaint about them paying $250 for the application. When you consider it's a lifetime savings, $250 is nothing.
Yeah, and again, we've never had pushback ever, right? It's like, oh my God, let me take care of this, right? It's simple. And I must admit, Dave, as well, and for everybody on the call, the people that Dave has on his team, the folks that help are caring, lovely individuals, and they have patience. And during a time when someone's struggling with a disease where they require a medication that is, $50, $100, $200,000, they need people to be dealing with them with patience and with dignity and with care. And the folks at Claim Secure check off all those boxes. So it's terrific.
And there are people on this call right now that have clients that are on this program and have some significant experience with it and results. So
so again, is it a perfect program? No, nothing's perfect. Tell me what's perfect. If you had endless amounts of money, sure, life can be perfect. If you're a billionaire, yeah, terrific. Sometimes, but you're still got, as somebody, we were talking about it last night, everybody's got a front door in their house and every front door looks different, but behind it, there's always shit. Okay. Everybody's got their shit, but this is just it's certainly a great prospecting tool, folks, without a doubt. Great discussions to have with your clients, ask future-based questions. Selling is engaging someone in a future result that is good for them. This can be part of that. It's 11 o'clock. We're going to wrap things up. So thank you very much on behalf of all of us at the Benefits Trust. Thank you very much for coming. A big, hey, Dave, thank you very much for joining us. Really appreciate it.
Thank you.
If we're doing business together, thank you very much. If we're not doing business together, we're open for business. We've got some inventory left on the shelves. We'd like to get rid of that inventory that we got on the shelves. So we are happy to help you out. Visit thebenefitstrust.com. Thanks for participating in our spring Zoomcast series, even though it's the first day of summer. We're going to be back with more Zoomcasts, certainly either later on in the summer or in the early fall. So make sure you check it out. You're going to be signed up for our newsletter. You're going to get a survey. Please fill it out, send it back. And Mike's going to send you a CE credit. If you want to stick around for a few minutes, we're going to stick around, but I'm going to stop recording and you can take off and get your CE credit. So thanks again, everybody.